So now let's discuss the treatment options for bleeding and platelet disorders. The first condition is thrombocytopenia caused by drugs. The first and foremost thing to do in such a condition is stop the offending drug. Usually the thrombocytopenia recovers within 7 to 10 days, but in cases of patients with significant bleeding or in patient with platelet count less than 10,000 per microliter, platelet transfusion can be done. However, there is no recommendation regarding the usage of platelet stimulating agents. The second condition is heparin induced thrombocytopenia. In this condition, discontinue heparin immediately, and in patients requiring anticoagulation therapy, use a direct thrombin inhibitor. Examples include lepirudin, which can be used in the dosage of 0.4 mg per kg of bolus, or it can also be used at 0.15 mg per kg per hour of infusion with a target of PTT or activated partial thromboplastin time of 1.5 to 2.5 times the baseline. The other alternative to lepirudin can be argatroban, which can be used in the dosage of 2 microgram per kg per minute infusion. Here, the activated partial thromboplastin time should be targeted to the range of 1.5 to 3 times the baseline. These are recommended in cases where there are treatment required for thrombosis. Use of low molecular weight heparin such as enoxaparin, dalteparin is not recommended, as the antibodies, that is the antiplatelet factor 4 or anti-PF4 antibodies, can cross react with low molecular weight heparins and worsen the heparin induced thrombocytopenia. Instead of heparin, fondaparinux can also be used as an alternative. In case of chronic ITP, patients usually do not require active management if there are no significant bleeding or if the platelet count is more than 40,000 per microliter. If treatment is needed, the recommended therapy is starting prednisolone in the dosage of 1 to 2 mg per kg per day and slow tapering to maintain a platelet count of more than 60,000 per microliter. Instead of prednisolone, even dexamethasone in the dosing of 40 mg per day for 4 days every 2 to 4 weeks can be used. In case of an active disease, intravenous immunoglobulin at the dosage of 2 gram per kg can be divided into multiple doses given over 2 to 5 days. This blocks the phagocytic destruction of platelets. In patients refractory to glucocorticoids, a trial of rituximab is recommended. L-Trombopag, which is a thrombopoietin agonist, can be used in the dosage of 50 milligram per day orally, and this increases the platelet production and delays the need for splenectomy, or even completely avoids the need of splenectomy. The other options include danazol, splenectomy, steroid sparing agents such as vincristine, cyclophosphamide, fludarabine are usually recommended in patients requiring prednisolone in the dosage of more than 5 to 10 mg per day during maintenance. Next condition is disseminated intravascular coagulopathy, or it is also called as consumption coagulopathy. Here, usually the trigger will be sepsis, so treat the underlying sepsis. In case of thrombocytopenia or bleeding, platelet transfusion or fresh frozen plasma or FFP is used to correct the clotting parameters. In patients with DIC secondary to acute promyelocytic leukemia, heparin can be used. The next condition is thrombotic thrombocytopenic purpura, or HUS. In this condition, rapid initiation of plasmapheresis and along with the FFP infusions in the form of plasma exchange or even intravenous immunoglobulin therapy are used. TTP or HUS carries a very high mortality, almost reaching up to 50% or more than 50%. But in prompt initiation of plasmapheresis and FFP or using IVIG, the mortality can be reduced to less than 1/3 the total occurrence. Here, the mechanism by which the plasmapheresis works is by removal of inhibitors of von Willebrand factor cleavage enzyme, that is ADAMTS13, and FFP transfusion replaces the enzyme. Other options for TTP and HUS include caplacizumab, which is an anti-von Willebrand factor single variable domain antibody. Anti-von Willebrand factor single variable domain antibody. It inhibits the interaction between von Willebrand factor multimers and platelets, leading to normalization of platelet count. In disorders of platelet function, try to reverse the cause. In cases of platelet dysfunction secondary to uremia leading to bleeding, dialysis or cryoprecipitate of up to 10 bags per day can be used. Hemostatic disorders, withdraw the offending drug, replace vitamin C, plasmapheresis can be used, and plasma infusions can be used in case of TTP. For treatment of hemophilia A, factor 8 replacement, especially in cases of bleeding or prior to surgical procedures. The replacement levels are dictated by the degree of bleeding or risk of bleeding during surgery. In cases of mild bleeding, factor 8 is replaced to obtain a 15% increase in activity level, or in case of severe bleeding, replacement is done to achieve a 50% of factor 8 activity level. The dosage of factor 8 is calculated using the formula target level minus baseline level multiplied by patient's weight in kg multiplied by 0.5. So this gives the number of units per kg required to achieve the target level of factor 8 activity. The difficulties of treating hemophilia A include up to 33% of the patients develop antibodies to factor 8. In such patients, activated factor 7 or factor 8 inhibitor bypass agent can be used to treat bleeding. In patients without the development of anti-factor 8 antibody, emicizumab, which is used in the dose of 3 mg per kg every other week, can also be effective. Emicizumab is a biospecific antibody that bridges the factor 9 and factor 10 to replace the function of factor 8. Latest studies have shown progress in gene therapy for factor 8 deficiency using adeno-associated virus 5 as vectors. Now let's look at the treatment of hemophilia B. Recombinant factor 9. Examples include Benefix or fresh frozen plasma or factor 9 concentrates. Commercially available examples include Proplex can be used. The dosing of factor 9 is calculated as follows: target level minus the baseline level multiplied by weight in kg multiplied by 1 unit per kg gives the daily dose of factor 9 therapy. As the duration of action is longer, once daily therapy is sufficient. Gene therapy using hyperfunctional factor 9 variant has been made available and is effective in reducing 80% of factor 9 infusions in patients. One Willebrand disease. Desmopressin increases the von Willebrand factor release from endothelial stores. This happens in type 1 von Willebrand disease. The dosing is for IV it is 0.3 microgram per kg, or for nasal route it is 2 squirts of 1.5 milligram per ml of fluid in each nostril. For types 2A, 2M and 3 of von Willebrand disease, cryoprecipitate, which is rich in factor 8 or factor 8 concentrate, can be used. The dosing of cryoprecipitate is up to 10 bags for 48 to 72 hours depending on the severity of bleeding. For vitamin K deficiency, vitamin K is given as 10 milligrams of subcutaneous dosing or IV dosing of vitamin K. And for liver disease, in cases with severe bleeding, fresh frozen plasma is preferred. Let's move to thrombotic disorders. The first one among them is hypercoagulable state. These are the patients with multiple episodes of venous thromboembolic events such as deep vein thrombosis or pulmonary embolism. The causes for such hypercoagulable state include venous stasis, more commonly seen in pregnancy and immobilization, vasculitis, cancer and myeloproliferative disorders, usage of oral contraceptive pills, lupus anticoagulant, where there is an antibody to platelet phospholipid which stimulates coagulation, heparin induced thrombocytopenia, deficiency of anticoagulant factors within the body, that is the endogenous anticoagulant factors including antithrombin 3, protein C and protein S, factor 5 lead-in, that is mutation in factor 5 leading to substitution of arginine in place of glutamine at 506th position. This leads to resistance to inactivation by protein C. Other causes include prothrombin gene mutation. Rare causes are paroxysmal nocturnal hemoglobinuria, dysfibrinogenemias, that is abnormal fibrinogen. Let's look at the treatment of thrombotic disorders. Wherever possible, correct the underlying disorder. And usually with recurrent thrombosis, lifelong anticoagulation, with warfarin or novel oral anticoagulants is recommended. Let's look at anticoagulant agents. The first one is heparin, which works by increasing the activity of antithrombin 3. It is available in two forms: the unfractionated heparin, which is a huge molecule, and low molecular weight heparin, dalteparin or enoxaparin. Wherever low molecular weight heparin is available, it is preferred over unfractionated heparin. Low molecular weight heparin comes with an advantage of easier administration by subcutaneous route and no requirement of measurement of activated partial thromboplastin time to guide therapy. Whereas unfractionated heparin is usually given in IV route for treatment and subcutaneous route is preferred for prophylaxis. And monitoring by activated partial thromboplastin time may be necessary, and when it is required, APTT in the range of 1.5 to 2 times the upper limit of normal is used as a target range for therapy. In patients with acute thrombotic event or venous thromboembolisms, heparin, that is unfractionated heparin, is initially loaded with 5,000 units IV as bolus, followed by infusions in the dosing of 25,000 units to 40,000 units as in IV infusions over 24 hours. That is approximately 1,000 unit to 1,200 unit per hour as infusions. In patients receiving low molecular weight heparin, the dosing of enoxaparin is usually 1 milligram per kg given as subcutaneous dose twice daily. Patients who are immobilized or in critical care units need a prophylactic dosing of low molecular weight heparin, which is usually given as 1 milligram to 0.5 milligram per kg as a subcutaneous dosing, usually once daily. In places where low molecular weight heparin is not available, unfractionated heparin is given in the dosing of 5,000 units subcutaneously twice daily or 3 times a day. Now, the complications of heparin include severe bleeding, and rarely heparin induced thrombocytopenia can be seen, which is type 1 and type 2. In patients with bleeding or fall in platelet count to less than 1 lakh per microliter, it is recommended to stop heparin immediately, and if the requirement of anticoagulation is present, switch to a different anticoagulant such as lepiridine or bivalirudin or even fondaparinux. In cases with severe bleeding, protamine can be used to neutralize the effect of heparin. The dosing of protamine is 1 mg for every 100 units of heparin given. The next anticoagulant that we'll be looking at is warfarin, also goes by the name coumadin. This is a vitamin K antagonist, and it reduces the levels of vitamin K dependent clotting factors, including 2, factor 7, factor 9 and factor 10, and anticoagulant endogenous factors, that is protein C and protein S also. In patients needing warfarin therapy, the dosing is initiated at 5 to 10 milligrams per day initially, and it is titrated to achieve an INR of 2 to 3, or if prothrombin time alone is used, a prothrombin time of 1.5 to 2 times the upper limit of normal is achieved, and the dose is titrated accordingly. Let's look at the complications of warfarin. One of the most dreaded complications of warfarin is warfarin induced skin necrosis. Let's try to understand what happens in warfarin induced skin necrosis. Warfarin inhibits all the vitamin K dependent clotting factors. However, it inhibits protein C and protein S initially, and followed by the 2, 7, 9 and 10. And as the protein C and protein S are affected first, there is an initial prothrombotic state, and this can lead to thrombosis or microvascular thrombi, leading to skin necrosis. To prevent this dreaded complication, warfarin therapy is usually bridged with heparin injections over the initial 5 to 7 days until the target INR is achieved. Other complications include hemorrhage and teratogenicity. In cases of bleeding, the warfarin effects are neutralized by administration of vitamin K in IV dosing. In patients with serious bleeding, FFP can be used for urgent reversal. Let us now look into some of the drug interactions in warfarin therapy. There are a few drugs which potentiate the action of warfarin, and there are a few drugs which inhibit the action of warfarin. The drugs that potentiate the action include chlorpromazine, chloral hydrate, sulfonamides, chloramphenicol, other broad spectrum antibiotics, allopurinol, cimetidine, tricyclic antidepressants, disulfiram, laxatives, thyroxine, clofibrate, high dose salicylates. The drugs that inhibit the effects include vitamin K, barbiturates, rifampin, cholestyramine, oral contraceptive pills, and thiazides. Let's move on to the next anticoagulant, that is fondaparinux. This is a pentapeptide that directly inhibits factor 10A. This is usually given at a dose of 2.5 milligram subcutaneous daily in case of prophylaxis, 7.5 milligrams subcutaneous daily in case of treatment of thrombosis. There is no monitoring required. The advantage of fondaparinux over heparin is there is no heparin induced thrombocytopenia that occurs with fondaparinux. Other direct factor 10A inhibitors include apixaban and rivaroxaban. Both are oral formulations. Apixaban is given in the dose of 5 milligrams orally twice daily. It is at least as effective as warfarin in DVT and more effective in prevention of stroke in atrial fibrillation. The next anticoagulants are DOACs or direct oral anticoagulants. These include rivaroxaban, apixaban, edoxaban, and dabigatran. These are targeted against the following. Rivaroxaban is a factor 10A inhibitor. Apixaban is a factor 10A inhibitor again. Edoxaban is also a factor 10A inhibitor, whereas dabigatran is thrombin inhibitor or direct thrombin inhibitor. Bioavailability of rivaroxaban is 80%, of apixaban is 60%, of edoxaban is 50%, and dabigatran is just 6%. The renal excretion is 33% for rivaroxaban, 25% for apixaban, 35% for edoxaban, and almost 80% for dabigatran. The dosing is for rivaroxaban it is once a day or twice a day dosing. For apixaban it is twice a day dosing. For edoxaban it is again once a day dosing, and for dabigatran it can be once a day to twice a day dosing. Let's talk about the in-hospital anticoagulation. It is usually initiated with heparin, and low molecular weight heparin is usually preferred. It is done for 4 to 10 days with a subsequent maintenance with warfarin after an overlap or bridging of 3 to 5 days. Duration of therapy depends on the condition for which the anticoagulant is initiated. For example, a calf deep vein thrombosis with a clear trigger requires a minimum of 3 months of anticoagulation. For a patient with proximal deep vein thrombosis or the cause is unclear, that is idiopathic DVT, the anticoagulation is usually prolonged for up to 6 months to 12 months, that is 1 year. Pulmonary embolism also warrants a therapy with anticoagulants for at least 6 months to 1 year. An embolic disease with ongoing risk factors such as atrial fibrillation will require a lifelong therapy. Warfarin versus NOACs. The first one is cost. Warfarin is cheaper compared to NOACs. The bleeding risk is higher in case of warfarin and lower in case of NOACs. The efficacy, warfarin is used for comparison with NOACs, and in most of the cases NOACs are almost equally effective, if not more effective. However, in one condition where NOACs are not effective or not preferred is anticoagulation after valve repairs or valve replacements. The reversal of anticoagulation to stop the bleeding is quite easy with warfarin, with injection of vitamin K, which is given intravenously, or in cases of severe bleeding, fresh frozen plasma can be used. The factor 10A inhibitors require reversal agent, that is adexanet alpha, which is a modified recombinant factor 10A, which acts as a decoy for factor 10A inhibitors. And for dabigatran, that is a direct thrombin inhibitor, idarucizumab, which is a monoclonal antibody fragment with high affinity to dabigatran, can be used. So these options are quite expensive compared to a simple injection of vitamin K or FFP transfusion. The next topic is fibrinolytic agents, tissue plasminogen activators or TPAs. They mediate clot lysis by activating plasmin, which further degrades fibrin. The commercially available preparations which are tissue plasminogen activators include streptokinase, urokinase, anistreptase, which is an acylated plasminogen streptokinase activator complex, and recombinant tissue plasminogen activators including alteplase, reteplase, and tenecteplase. Now let's look at the indications for fibrinolytic agents. These include treatment of DVT, where there is reduced incidence of post-phlebitic syndrome, including chronic venous stasis or venous skin ulcerations as compared to heparin. Fibrinolytic agents are also used in massive pulmonary embolisms, arterial embolic occlusion of extremity, in treatment of acute myocardial infarction, unstable angina pectoris. Let's look at the dosing of fibrinolytic agents. Tissue plasminogen activator in cases of acute pulmonary embolism or acute myocardial infarction. A 10 milligram of IV bolus is given over 1 to 2 minutes, followed by 50 milligrams IV over 1 hour, and then 40 milligrams IV over the next 2 hours. So this leads to a total dosing of 100 milligrams of tissue plasminogen activator. Tissue plasminogen activator is slightly more effective but more expensive also when compared to streptokinase. The second fibrinolytic agent that we are looking at is streptokinase. In case of acute myocardial infarction, 1.5 million units of streptokinase is given as infusion intravenously over 60 minutes, or 20,000 units of streptokinase as intracoronary bolus, which is followed by a 2000 unit per minute infusion, again intracoronary, over 60 minutes. For acute pulmonary embolism or arterial or deep vein thrombosis, an initial dosing of streptokinase of 2,50,000 units is given over 30 minutes. This is followed by 1 lakh units per hour infusion for 24 hours in case of pulmonary embolism, and 1 lakh units per hour infusion for 48 to 72 hours in case of arterial or deep vein thrombosis. The next fibrinolytic agent is urokinase, which is given for pulmonary embolism in the dosing of 4,400 international unit per kg as IV dosing over 10 minutes, which is followed by a 4,400 units per kg per hour of infusion, which is given IV over 12 hours. Some points to note in general about fibrinolytic therapy includes it is usually followed by a period of anticoagulant therapy, usually with heparin. Fibrinolytic agents are contraindicated in patients with active internal bleeding, a recent cerebrovascular accident within the last 2 to 3 months, intracranial neoplasms or aneurysms, or recent head trauma. Let's now jump to antiplatelet agents. The first one is aspirin. This inhibits platelet function by blocking the ability of cyclooxygenase 1 to synthesize thromboxane A2. So this action is blocked. The thienopyridines, examples include eclopidin, clopidogrel or prasugrel, inhibit ADP induced platelet aggregation by blocking its receptor P2Y12. Hence, this is also called as P2Y12 inhibitors. Dipyridamole acts by inhibiting phosphodiesterase, leading to increase in cyclic AMP levels and block platelet activation. The other antiplatelet agents include glycoprotein or GP2B3A inhibitors. These act by blocking the integrin receptors on platelets and prevent platelet aggregation. The examples of GP2B3A inhibitors include abciximab, which is a FAB antibody fragment that binds to activated glycoprotein 2B3A. The second agent in that class is eptifibatide, which is a cyclic heptapeptide that includes a KGD tripeptide motif that is recognized by GP2B3A. The third agent in this class is tirofiban, which is a tyrosine derivative that mimics the KGD motif. Aspirin in the dosing of 160 milligrams to 325 milligrams per day. Clopidogrel in the dosing of 75 milligrams per day is used in lowering arterial thrombotic events such as stroke or myocardial infarctions. These are used especially in high risk patients.